cerebral artery Doppler, and the MCA PhD noted to be a 57.45 centimeter per second, in which is a more than 1.5 multiple of median. So during this time, our differential diagnosis were parvovirus infection, torches, hemolytic disease of newborn. In view of our first, we are thinking that the husband was normal. Okay. Okay, so this graph is showing at 26 weeks, the MCA PHB was a 57 centimeter per second, whereby it's a more than 1.5 multiple of median. So this indicates a moderate to severe fetal anemia. Okay. So as mentioned before, we did send the torches and parvovirus, and all the results were negative. Okay. So with additional finding of a cardiomegaly and reduced FI at 27 weeks, with a negative result for the torches and parvovirus, with so we highly suspicious of HB bugs. Therefore, husband was investigated again for thalassemia status, and not surprisingly, the result was alpha thalassemia with 2 gene deletion. Okay, so with all this finding, we can counsel again the couple for photosynthesis to confirm the diagnosis, and it was done at 29 weeks. Otherwise, mother remain normotensive throughout pregnancy, and she has no generalized edema. Okay, so now I would like to invite Prof. Azma from the pathology to present regarding a further investigation for the couple. Okay, Prof. Azma. Okay, Assalamualaikum warahmatullahi ta'ala wabarakatuh, and good morning everyone. Thank you, Dr. Nohafiza. Before I elaborate on patient laboratory findings, I would like to describe briefly on how we investigate patient with thalassemia. So this full blood count, we need to do full blood count for any patients suspected with thalassemia. So to look for the complete red cell indices, and then also iron status to ensure that there is no underlying iron deficiency anemia, and peripheral blood smear if needed. And if those tests showed abnormalities, we will proceed with Hb analysis that consists of Hbh Inclusion Screening, Hemoglobin Electrophoresis, and Hemoglobin quantitation by HPLC and Capillary Electrophoresis. For confirmation of thalassemia, we need to do DNA analysis. So for the full blood count, usually we run in fully automated system that highly sensitive that can screen thalassemia carriers. This method will measure the red cell indices such as hemoglobin, MCH, MCV, and RBC, which is very useful to differentiate thalassemia carriers from IDA. In thalassemia carrier, we can see that the patient usually has a very low MCH and MCV with normal hemoglobin or slightly low hemoglobin, and RBC most of the time will be slightly high. But if the patient has underlying iron deficiency anemia, all the red cells indices will be low, and this will mask the thalassemic features of RBC. We use MCH less than 27. So those that suspected thalassemia carrier with MCH less than 37, we will proceed with HB analysis. In thalassemia major, the hemoglobin will more anemia, severe anemia with low MCH, but sometimes MCV can be normal. This actually due to marked anisopoikilocytosis. The white cell count can be flat because of the circulating nucleated RBC. Some of the hemoglobinopathies or thalassemia carrier can have normal full blood count. So we might miss to detect this kind of patient in early stage. Peripheral blood smear. So what we can see from the peripheral blood smear, only hypochromic mucocytic red cells and target cells. Yeah? And for the thalassemia major, the hypochromic mucocytic will be more marked with severe anisopoikilocytosis, and when we can see circulating nucleated RBC. Only sickle cell that we can diagnose from peripheral blood phlegm, not other thalassemia. So this is example from our own patient, thalassemia patient. So figure A, thalassemia trait. This patient has a mild hypochromic mucocytic red cells, occasional target cells, and mild anisopoikilocytosis. And figure 2, example of patient with thalassemia major. The hypochromic mucocytic red cells are more marked, numerous target cell can see, severe anisopoikilocytosis, and we can see there is circulating nucleated RBC. Okay, so Hbh inclusion screening is part of the Hb analysis. So we stain the peripheral blood phlegm with new methylene blue to look for the presence of Hbh inclusion. So when there is Hbh, we can suspect there is alpha genes involvement. Hbh inclusion actually due to beta chain tetramers that develop due to lack in the alpha globin chain. So this Hbh is very unstable and it will be precipitate below the red cell membranes. That's why we can get this Hbh inclusion when we do supravital stain. Okay, so other Hb analysis such as hemoglobin electrophoresis, so we can detect abnormal hemoglobin by this method. By doing HPLC and capillary electrophoresis analysis, we can look for the abnormal hemoglobin, plus we can quantitate the major hemoglobin. So for beta gene abnormalities, we look for the changes or raise in the hemoglobin F or hemoglobin A2, while for alpha abnormalities, we look for the presence of HbH and HbBARs, but only those with 3 or 4 gene deletions can be detected by Hb analysis, not those with single or 2 gene deletions. Other hemoglobinopathies that can be detected by Hb analysis, such as hemoglobin Lepo, E, S, C, and also hemoglobin Coulson screen. So by doing hemoglobin electrophoresis, we have to look for the presence of abnormal band. However, not all hemoglobin can be detected. Some of the hemoglobin can degrade very fast. For example, hemoglobin Coulson screen. And by doing this electrophoresis, we be able to separate many types of hemoglobin, such as hemoglobin A, hemoglobin F, HbH, and HbBARs. However, these two groups of hemoglobin, S, D, G, Lepo, and C, A2, E, and O, cannot be separated from each other. So we can see from this figure A, in lane 4, this band, there is a normal band here, run together with hemoglobin C. So we are not sure, actually, is it C, E, or A2? Yeah? But Malaysian, hemoglobin C is rare, usually African people. So more common is hemoglobin E. So we suspect this, most likely the patient actually has hemoglobin E. So in figure B, there is HbH band here. So we can suspect this patient most likely has HbH disease. Okay, so HPLC is an equipment that utilizes a weak cation exchange column. Hemoglobin will be absorbed onto the column saturated with low ionic strength buffer, and with increasing ionic strength of buffer, hemoglobin will be elute out. And different type of hemoglobin has different retention time. So with this method, we will be able to detect abnormal hemoglobin, and we can quantify both major and abnormal hemoglobin. However, few hemoglobin will be has an overlap retention time, such as A2, E, and Lepo. So how we decide which is which? We look for the percentage of the hemoglobin A2. For example, in figure B, the A2 is raised, but not more than 10%. So most likely, this is beta thalassemia trait. In figure C, the percentage of A2 is more than 20%. So most likely, this patient is having HBE. While in figure D, there is presence of abnormal hemoglobin at S window. So probably this patient has hemoglobin S. So that's how roughly we diagnose patient from HB analysis. However, HB bars and HbH are unable to be quantitated by this method, but we can detect, we can look for the presence of the pre-run P I will show later. Okay, so that's another method of quantitation of hemoglobin by doing capillary electrophoresis. This method utilizes a thin capillary of silica. Inner surface has a negative charge, so with high voltage introduced, it will cause the capillary to generate endoosmotic flow towards the cathode. So hemoglobin will be separated because of the different charge fraction moved towards the cathode because of the endoosmotic flow. So this method also can detect and quantify major and abnormal hemoglobin. For example, figure A, there is small peak here at this zone. So hemoglobin C and hemoglobin constant spring has a similar zone. So since in Malaysia, most likely this is constant spring rather than hemoglobin C. Okay, so hemoglobin B, there is presence of hemoglobin E and hemoglobin A2, two peak here. So we can see that by doing capillary electrophoresis, hemoglobin E is separated from hemoglobin A2. So since there is major hemoglobin A here, so most likely this patient has compound hemoglobin E beta plus. Yeah? Hemoglobin C, there is a peak for hemoglobin E here, peak for hemoglobin constant spring because this is sample from Malaysian population. So most likely this peak is come from hemoglobin constant spring. So this patient C has a concomitant hemoglobin E with hemoglobin constant spring. And then from by analyzing capillary electrophoresis, we will also able to detect HB bars and HbH. This is HPLC. We can see presence of pre-run peak here. We can suspect this is HB bars, but by using HPLC, we are unable to quantify the HB bars. But by doing capillary electrophoresis, HB bar can be quantified. So this capillary electrophoresis can be used to screen alpha thalassemia trait for the newborn. Okay, so this is a DNA analysis. In SUKM, we use multiplex arms to detect point mutation in alpha and beta genes, while for deletion alpha and beta gene, we use multiplex gap PCR method. So we select primers based on common mutation that found in Malaysia population. So if DNA analysis by multiplex PCR negative, we will send for the sequencing to look for the rare gene abnormalities that usually can be detected by this sequencing method. So other than whole blood or blood samples, we can also do prenatal diagnosis. Yeah? So we can get chorionic villus sampling or amnion synthesis and cord blood samples, and then do DNA analysis to confirm thalassemia in utero. So what about inheritance patterns? For alpha thalassemia HbH, if one of the parent has two generation and another parent single generation, 25% chances actually the offspring will be HbH. So if two parents, both parents has two generation, so 25% chances of their offspring will be hydrophytalis. And for beta thalassemia, if both parents carrier, so 25% chances of their offspring will be thalassemia major. So what about our patient? So the first sample that we received from the patient in 2011, yeah? So we can see that her full blood count showed a severe anemia, MCV low, MCH low, yeah? RBC is borderlinely low, HB analysis is consistent with HbH disease, and her DNA analysis consistent with alpha gene deletions. So when in her first marriage with her first husband that has two alpha gene deletions, was informed that their child is normal, but I don't have the result or laboratory test of their first child. With her second marriage, we received sample of the patient's husband when the patient at 27 weeks of gestation. So her husband showed normal hemoglobin, RBC slightly raised, but hypochromic microcytic red cells. His HP analysis is normal, but when we do DNA analysis, there is two gene deletions of alpha thalassemia. And so we also receive codal synthesis samples from the second child. So the full blood count of the cord sample showed severe anemia, low RBC, and a low MCH. The MCV is normal because of marked anisoproteinocytosis, as I mentioned earlier. And we can see there is flagging in the white blood count. So this most likely due to circulating nucleated RBC. So HB analysis and DNA analysis, I will show later here. Okay, so this is figure A. Is a result from the baby, the fetus. So this is HPLC. We can see there is a pre-run peak here, but by using HPLC, we cannot quantify the hemoglobin bus. There is no major hemoglobin. There is no hemoglobin F, A2, or hemoglobin A. From the capillary electrophoresis, the HB bus can be quantified by this method. So patient has 83% HB bus plus other fetus hemoglobin such as Portland and Gower. But there is no hemoglobin A, major hemoglobin A, hemoglobin F, as well as hemoglobin A2. Okay, so and the hemoglobin electrophoresis of the baby showed presence of hemoglobin Portland and HB bus. So with this finding, we conclude that the baby is consistent with hemoglobin bus. And the patients, this is HB analysis of the patient by capillary electrophoresis. There is major hemoglobin A here with presence of peak of HbH. And the hemoglobin electrophoresis of the patient showed presence of HbH band here. So this is consistent with hemoglobin H disease. And the supravital stain done on peripheral blood smear of this patient also show presence of Hbh inclusion. And this is DNA analysis of the patient and second husband plus the second child. So the cord blood sample, cord blood sample of the fetus showed 4 gene deletions. Patient sample showed 3 gene deletions. And the second husband has 2 gene deletions of alpha. So for the inheritance patterns of this patient's family, since patient has HbH and the father is carrier for 2 gene deletions, so there are 25% chances to have HbH baby, 25% chances to have HB bus, and the other another 50% will be carrier. So the first child most likely to have either 2 gene deletion or single gene deletion alpha. Thank you.
Thank you, Prof. Azma. I'll continue with case presentation. So after review the codal synthesis result, our working diagnosis during that time was hydrocephalus secondary to alpha thalassemia with 4 gene deletion. Okay, so for the mother, she required 1 pint blood transfusion at 29 weeks, whereby she had a moderate anemia with HB of 8.8. And then she subsequently presented to UKMMC at 34 weeks in spontaneous preterm labor. She subsequently progressed into delivery after 6 hours of admission. She delivered a baby boy with a birth weight of 2 kg. The baby noted to have a generalized edema and unfortunately passed away at 1 hour of life. The delivery was complicated with a retained placenta and primary PPH, in which require MRP in OT. Intraoperatively, we noted that the placenta edematous and the cord was fibered, in which patient required suction and curettage under ultrasound guidance. Post-procedure, she was transfused with 1 pint blood, and then Hb post-transfusion was 7.5 gram. So she was discharged the next day. Okay, I think that's all for the first case. Okay, I will continue with the second case. Okay, this is a 33-year-old Gravida 2 para 1 with a MCDA twin pregnancy and Hbh beta thalassemia. She was initially diagnosed with a Hbh beta thalassemia about 10 years ago in 2011 in Hostel Sunabaya. She was followed up there for about a year, but subsequently she defaulted the follow-up. She has no history of blood transfusion before. Okay, she then married in 2015, had her first pregnancy in 2016, and antenatally she required about 4 times of blood transfusion. She managed to carry that pregnancy till term, whereby she delivered vaginally at EDD plus 4 days. It was an uncomplicated delivery. She delivered a baby boy with a birth weight of 2.79 kilo. Okay, so this patient as well has a strong family history of a beta thalassemia. Her parent and younger sibling were carrier, while her older brother has a beta thalassemia major who had passed away at the age of 37-year-old due to the complication of the thalassemia. Okay, she is otherwise a lab technician. She married to a clerk and her husband has no thalassemia. Okay, so for her current pregnancy, she was seen here as early as 10 weeks, whereby she presented to our PAC with symptom of anemia, and during that time, her Hb was noted to be 7.4 gram. She required 1 pint per cell transfusion and subsequently discharged home. She was seen again 1 week later at our antenatal clinic. So during that time, she's clinically looked pale. Her BP normal, 100/60 mm mercury. She's otherwise not tachycardic. Her BMI was normal, 19.8 kg per meter square. And her Hb during that time was 8.4 gram. For abdomen, there's noted a splenomegaly. Uterus was palpable about 16 weeks. And ultrasound was performed and it's confirmed 2 viable fetuses. Her dates confirmed as well during that time. We proceed with anti-scan and it showed a low risk for both fetuses. Okay, this patient, she actually throughout her pregnancy, she required multiple times of blood transfusion, total of 7 times, and her Hb pre-transfusion ranging from the 7.3 to 7.8 gram. As for the fetus, we proceed with a detailed scan at 22 weeks, and both fetuses grossly normal. The growth between 5th to 50th percentile and the weight discrepancy between both fetuses was only 1 to 9%, which was normal. Okay, so we see her again at 34 weeks in our antenatal clinic for assessment of the fetus. So both fetuses were noted to be intraversal. So we counsel her regarding mode of delivery and we have planned for elective C-section at 36 weeks. So this is the pre-transfusion hemoglobin trend during the pregnancy. And this one is the ferritin level pre-pregnancy at 10 weeks as well as 30 weeks of gestation. It's showing an increasing trend. Okay. So she was admitted to UKMMC at 36 weeks plus 3 days. Hb on admission was a 9.7 gram. She was transfused with a 2 pint of blood. And then she had a section the next day. Intraoperatively, the both fetuses were intraversal and both were delivered via breech extraction. Surgery was uncomplicated with a blood loss for only 400 ml. Delivered 2 boys with a birth weight of 2.2 and 1.9 kilogram. The Hb post-operation was 8.1 gram. Okay, so I think this is my last slide, that one. So she was discharged after day 2 post-surgery. So with that, I thank you. And then I would like to invite Dr. Raja, Prof. Raja for further elaboration regarding the investigation for the beta thalassemia.
Sorry, everyone. So this is a full blood count of the patient at 10 weeks of gestation. Hemoglobin of the patient is very low with low RBC and markedly low MCV and MCH. The Hb analysis findings showed there is a raise in the hemoglobin F, very high hemoglobin F, hemoglobin E, and also A2, but there is no major hemoglobin A. So with these findings, we conclude that this patient is having hemoglobin E beta not thalassemia, and husband was told to have normal laboratory investigations. So this is DNA analysis findings of the patient. So we run two method of the we run twice using multiplex arms A and multiplex arm B. So from arms A, we detect the CD26 or hemoglobin E thalassemia, while in beta arms B, there is a presence of LVS11 beta globin gene mutation. So we conclude that the DNA analysis of the beta gene abnormalities in this patient is hemoglobin E with IVS11. We also run for alpha thalassemia, since the patient, even though has hemoglobin E beta not, but she was not regularly transfused before until during pregnancy. But the alpha thalassemia gene abnormalities is normal in this patient. Okay, so for this patient, since the mother is thalassemia major, the patient thalassemia major with normal husband, so all of her offspring will become a carrier for beta thalassemia. Okay, that's all. Thank you.
Thank you very much to both Dr. Hafizah and Prof. Raja Zaratul Asma for very interesting presentation, and as well as elaborating on the investigation that is usually been done. So after this, it's going to be a very interesting presentation by Dr. Jamila, talking about the status and the situation of thalassemia management in Malaysia. Please, Dr. Jamila, your turn. Thank you.
Thank you, Prof. Shuhaila. Thank you, Prof. Shuhaila, for the kind introduction. Can I have it in PowerPoint? Thank you. Thank you, Dr. Rahana, for showing my slides. Yeah. So what I'll do is I'll give you a brief overview of thalassemia, how it is a major public health burden in Malaysia, and then discuss around the case. So the common thalassemia syndromes in Malaysia are HBE beta thalassemia major, HBH disease, and HB Bart's hydroxyspitalis. The first two are beta thalassemias, and the second two are alpha thalassemias. So thalassemias are very common in Malaysia, in Southeast Asia and in Malaysia as well. And why I say it's a public health burden is that, especially for E beta thalassemia, the severe ones, and the beta thalassemia major, is a lifelong transfusions for them, and they require also iron chelation. So to treat one thalassemia in their lifetime up to about 40 years of age, they will require about close to, I would say, about 3 to 4 million ringgit. Yeah. So 1 million ringgit for every 10 years of life, for all the treatment they have to undergo, because they develop many complications from iron overload, such as heart failure, liver failure, osteoporosis, diabetes, hypoparathyroidism, hypothyroidism, the whole works. I always tell my young doctors that if you treat thalassemia major, you'll know the whole of medicine, because they have all the complications. Next slide, please. So this is our thalassemia registry. I only have the update, the 2018 data, which is updated. The 2020 data is not updated yet. And And of course, it still shows the proportion of thalassemia is still the same, such that the E beta thalassemia is the highest, yeah, at 2,744, yeah, and followed by beta thalassemia major, and then followed by Hbh disease. I think now our 2021 data, we are already approaching 9,000 patients. Yep, so but the proportion is about the same. Highest E beta thalassemia followed by beta thalassemia major and then Hbh disease. Next slide. Okay, why is this so? Why do we have all these thalassemia syndromes, yeah, which is commonly seen in Malaysia? Because our thalassemia carrier rate is high. And in a study that we did, yep, in a secondary school in front of our hospital Ampang, we found that 1 in 10 of the students are carriers for either beta thalassemia, E, or alpha 0 thalassemia. So that is very high, huh? 1 in 10. I think other papers quote 1 in 20, and that's only for beta thalassemia carrier. Next slide. So what are the common and significant thalassemia carriers? They are the hemoglobin E, beta thalassemia, and I've listed down the 3 most common mutations seen in both Malays and Chinese, the IVS15, IVS11, and the codon 4142. And the alpha thalassemia carriers, most commonly is the 2-gene Southeast Asian deletion. SEA stands for Southeast Asian deletion, and also HB constant spring. So the most common are the deletions, yeah, for alpha thalassemia carrier, followed by HB constant spring is actually a point mutation. So in the mutations in beta thalassemias are usually point mutations, while the alpha thalassemias are usually deletions. But you can still have deletions in beta thalassemia and point mutations in alpha thalassemia. Next slide. So just a little bit about terminology in beta thalassemia. Okay, so for non-carriers or a person who is normal, they have 2 beta genes. So the beta globin genes are located on chromosome 11. So in normal individual, we have 2 beta genes. So it's written beta beta. Next, beta thalassemia carrier is written beta naught or beta plus and beta. Yeah, so they have 1 normal beta gene. So there's 1 normal beta, and the beta 0, yeah, meaning that this beta gene does not produce any beta chain. So we put down there beta naught. Yeah, beta naught. Yeah. So HBE carrier is written beta E beta. Yeah. So a carrier will have 1 normal beta gene. Next. Okay. So for alpha thalassemia, the terminology, in a normal individual, we call it, or non-carrier states, we have 4 normal alpha genes. Yeah. 2, we get 2 from mom and 2 from dad, yeah? And the alpha globin genes are located on chromosome 16. So it's different from beta globin gene. Beta globin gene is located on chromosome 11. Okay, next slide. So the common deletion that we see in Malaysia is the alpha 0. It's written alpha 0, yeah, because 2 of the gene, yep, is deleted on the same side of the chromosome. So dash dash alpha alpha. So for alpha 0, they have 2, yep, normal alpha gene on the same chromosome. Alpha plus is written, yeah, it's actually 1 gene deletion. It's written dash alpha 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 because 1 of the alpha gene is deleted. Yeah. So we're not so worried about the alpha plus, yeah, because an alpha plus marrying an alpha plus, you'll get homozygous alpha plus, yeah. But we are more concerned about alpha 0 because alpha 0 marries another alpha 0. You may 25% chance of getting, yeah, hydrops fetalis. Hbh hydrops fetalis is 4 gene deletion, as you've seen in the first case. So alpha non-deletional, yeah, the common one in Malaysia is HB constant spring. So it's written there alpha T, yeah, could be constant spring or even Adana, yeah, but Adana is very rare, but constant spring is more common in Malaysia. So alpha T alpha alpha alpha. So 1 of the alpha gene is dysfunctional, yeah. So HB constant spring is actually a stop codon mutation. It's a point mutation and it's highly unstable, yeah. Next slide. So the terminology for thalassemia syndromes. Next slide. For beta thalassemia major, we write it as beta not, beta not. Yeah. So they are transfusion dependent for life. For beta thalassemia intermediate, they may have one beta gene which is producing some beta chains. So it's either written beta, they're either homozygous for beta plus or beta not beta plus. Yeah. So what it means by beta not is they don't produce any alpha chains. Beta plus produce some beta chains. HbE beta thalassemia, yeah, is beta E beta not or beta E beta plus. And for alpha thalassemia, Hbh disease is 3 gene deletion, so dash alpha, so they have one alpha, good alpha gene. For Hbh constant spring, they have 2 deleted alpha gene, but there is one alpha gene which is mutated with, so it's dysfunctional. That is the alpha constant spring alpha. So between Hbh disease 3 gene deletion and Hbh constant spring, which is a severe one? Can you guess? Or can you make a good guess? You would think that maybe Hbh constant spring because the alpha is still there, but actually Hbh constant spring is more severe than Hbh disease because constant spring is highly unstable. And also the good alpha gene does not actually upregulates itself because he thinks that his partner is there and working, but he doesn't realize that he's not working well. So it doesn't upregulate itself, unlike the Hbh disease with 3 gene deletion, because the single alpha gene there, he knows that he's the only one left behind, so he works harder. But over here, this alpha gene thinks his partner is working well, so it doesn't work harder, yeah? But also because this is highly unstable. And then you have the Hbh Hydrops Vitalis with 4 gene deletion, which is incompatible with life. Next slide. So, because thalassemia is so prevalent in Malaysia, we need to do thalassemia screening, okay? So, we look for the prevalent mutations in your country. In the UK, they do newborn screening for sickle cell anemia because they have a lot of blacks in UK. But over in Malaysia, because the most common thalassemia syndromes are beta thalassemia major, E beta thalassemia, and alpha Hbh Hydrops Vitalis or Hbh disease. So we screen for the carriers of beta thalassemia, HbE, and alpha 0 thalassemia. Okay, alpha 0 thalassemia, namely the Southeast Asian deletion. So a person can be a carrier for both alpha and beta thalassemia mutations because the alpha and beta globin genes are on separate chromosomes. Yeah. Next slide. Okay, this is the diagram to show you the deletional alpha mutations. Yeah, so like I said, the common deletional 2 gene deletion mutation in Malaysia is the Southeast Asian deletion, seen here in the blue, right? There are also other 2 gene deletion mutations, two alpha gene deletion mutations, which is the Mediterranean. The one right on top, the long one. Yep. Don't look at the 1 gene deletion. Yep. Look at the 2 gene deletion, the Mediterranean, the Thai deletion, and the Filipino deletion. Yep. So there are 4 types of deletional alpha mutation, 2 gene deletion: Mediterranean, Southeast Asian, Thai, and Filipino. But the more severe one is actually the Southeast Asian. Although it is not a very large mutation it is not a very large deletion compared to the Mediterranean, Thai, and Filipino. Why is it more severe, although the deletion is not so large? It's because the deletion spares the embryonic gene, that is the zeta. So it's still able to produce the embryonic hemoglobin. So these fetuses will be able to survive. And then when it comes to the 2nd and 3rd trimester, they become hydrops because these embryonic hemoglobins are unstable. So that's why the Southeast Asian deletion is the most feared one, because it can cause Hbh Hydrops Vitalis, because the other Mediterranean, Thai, and Filipino deletion get very early spontaneous abortion. So they don't go to the stage of Hbh Hydrops Vitalis because this embryonic zeta gene is deleted for the large deletions. But for Southeast Asian deletion, this zeta gene is not deleted. So the fetus still is able to make embryonic hemoglobin and able to survive longer and cause Hbh hydrops fetalis and the complications to the mother as well. Next slide. I hope you understand. So coming to the first case, mom has Hbh disease, yep, the 3 gene deletion, and the 2 gene deletion is the Southeast Asian deletion. Her booking hemoglobin is 10. First husband is alpha-0 thalassemia carrier, the 2 gene Southeast Asian deletion. And the first child was said to be normal, but it's not normal. It's not Hbh or hydrops. The child will be either 1 gene or 2 gene deletion carrier. Yeah. The second husband also turned out to be alpha-0 thalassemia carrier when the fetus was noted this current pregnancy at 27 weeks to be hydrops. So you see, alpha-0 thalassemia carrier is common in Malaysia. Yep. So you need to screen for these alpha-0 thalassemias because they cause a lot of problems. Yeah. Especially hydrops, Hbh and hydrops fetalis. Next slide. So I think Prof. Azma has already showed you the risk of this couple having a Hbh hydrops fetalis, yep, 25%, 25% alpha-0 trait, 25% Hbh disease, and 25% alpha plus trait, yeah? So that's their risk of inheritance. Next slide. So at 31 weeks, the hemoglobin was noted to be 8.8 and 1 unit packed red blood cell was transfused. So when I looked through the case presentation, I asked the question, next, when should you or should you not transfuse blood in a thalassemia patient during pregnancy? And then the second, what I noticed was this patient's pregnancy was confirmed to be Hbh hydrops fetalis at 31 weeks, and she was allowed for pregnancy to continue. So the next question is, why was termination of pregnancy not done earlier? Yeah. Yep. So why? What is the indication for and or not for transfusion in non-transfusion dependent thalassemias? We call this NTDT, yeah, for short-term NTDT, non-transfusion dependent. So so we usually do not transfuse a pregnant mother with thalassemia if they are not transfusion dependent, if they are able to maintain hemoglobin above 8 throughout pregnancy. So if it's above 8, yeah, usually the fetus can grow well, yeah. Especially in non-transfusion dependent thalassemia, the mother will tolerate lower hemoglobin better. For those who are on regular transfusion, for those who cannot maintain hemoglobin above 8, so they are for regular transfusion. Yep. So we need to keep pre-transfusion Hb above 8 throughout pregnancy. Okay. So if a non-transfusion dependent thalassemia can maintain, so I summarize, okay? So a non-transfusion dependent thalassemia, if they can maintain the hemoglobin above 8 throughout pregnancy, usually they can go without blood transfusion. But for those, if their hemoglobin falls below 8, yep, they may require blood transfusion during their pregnancy. And this is taken from the RCOG Green Top Guidelines, yeah. Next slide. So very important, all thalassemias must have baseline red blood cell phenotyping. Yeah, I hope you all understand what is RBC phenotyping. Yeah, so it's not just ABO big D. There are a lot of other red cell antigens, yeah, on the red blood cell. Okay, and all pregnant thalassemia patients must have red blood cell antibody screening at booking and at 28 weeks. Actually, not just for thalassemia in pregnancy, for all pregnant mothers should have red cell antibody screening at booking and at 28 weeks, especially for pregnant mothers with thalassemia. And if they are for transfusion, yeah, blood must be phenotype matched, not just ideally they should be matched at most of all these antigens, but it's very expensive. So we could say if you can match them at ABO and the RHCDE, that would be good, but better if you can match them even for Duffy, KIT, and MNS, because they may develop antibodies, because these are patients who are on, especially for those who are on regular transfusion, yeah? Okay, so ABO, so CDE are the ones most immunogenic after the ABO, yeah? That is your RH and antigens. Okay, next slide. So why was termination of pregnancy not done? Okay, because I know why. We need to actually, once we diagnose HB Bart's hydrops, we need to terminate the pregnancy because of the dangers to the mother, because of the risk of severe preeclampsia, and it can occur very suddenly, yeah, and the risk of primary postpartum hemorrhage. So it is so urgent TOP is indicated once HB Bart's hydrops is diagnosed. I think there are reasons for not doing an urgent TOP. I think Dr. Rahana will explain. Next slide. So of course, this first case, she needs to undergo genetic counseling. Future pregnancy must be planned. So she needs to undergo either early prenatal diagnosis or consider for pre-implantation genetic diagnosis, or PGD. Dr. Rahana will also explain this. Folic acid supplement throughout pregnancy and also throughout their life. And contraception is actually safe for thalassemia patients. Next slide. So we come to case number 2. So this is a young lady who was diagnosed at 23 years of age, not sure the baseline hemoglobin. She had blood transfusion during the first pregnancy. She presented at 10 weeks, age 33 years old, with a hemoglobin of 7.4. So, at booking, HB 7.4. So that's quite severe anemia. She had a large spleen. I'm not sure about the serum. I don't think the serum ferritin was given, but look, when we screen her notes, her ferritin was about 200, and she had a twin pregnancy, so she was not really iron overload. Yeah. Next slide. So during her from 13 to 33 weeks, she had a total of 7 times blood transfused, and a pre-transfusion hemoglobin range between 7.3 to 7.8. Fetuses, good growth at 50th percentile. She had elective LSCS at 36 weeks for breech and twins, and good birth weight for both fetuses, 2.2 kilogram, 1.9 kilogram, and her pre-op hemoglobin was 9.7, post-op hemoglobin was 8.1. Next slide. So, so this young lady has moderate to severe thalassemia because she required blood transfusion during a pregnancy. There's periods of increased demand. Her first pregnancy, she required 4 times blood transfusion. She had a large spleen. Hemoglobin was below 8, that is 7.4 at 10 weeks gestation. She had a twin pregnancy, and her older brother died at 37 years old due to complications from thalassemia. So it sounds like she has moderate to severe thalassemia. So the decision is for her to undergo regular transfusion for both maternal and fetal well-being, to keep the pre-transfusion hemoglobin above 8 throughout pregnancy, and importantly, blood must be phenotype match, to prevent alloimmunization, alloantibodies and hemolytic transfusion reactions. Next slide. So what you need to assess, ideally, you need to assess a patient before they become pregnant. We need to screen a partner. We need to run a HB analysis, and then plus minus a DNA analysis. Next slide. Check for iron loading. Yep. Serum ferritin. Yep. Organ function, heart, liver, endocrine, all the endocrine system, especially if they are iron overload. Next slide. And kidney function too, because recurrent hemolysis, especially with Hbh disease and also with E-beta thalassemia, they are unstable. So they may have hemolysis during fever, infection, and so the hemoglobin, the free hemoglobin can damage the kidneys. Yeah. Next slide. So what you also need to assess is, of course, I've emphasized this, baseline red cell phenotyping, if not previously done. Hepatitis B, C, and HIV screening. Make sure that their hepatitis vaccination is up to is given if their antibody levels have fallen. If they are splenectomized, then you need to ensure that they get pneumococcal vaccination and penicillin prophylaxis. If they're allergic, then they get erythromycin. Iron chelation, optimized chelation if they are iron overload prior to conception. And during pregnancy, we need to stop all oral iron chelators, and desferoxamine, which is given subcutaneously, is safe after 20 weeks. We need to review the mom monthly until 28 weeks and fortnightly thereafter, and monitor fetal growth. I think Dr. Rahana will explain to you how often they monitor fetal growth and well-being. Next slide. So when do we transfuse these patients? If they are non-transfusion dependent thalassemia, that means they are mild to moderate. It actually depends on the severity of the maternal anemia. In non-transfused patients, as in the first case, if hemoglobin can be maintained above 8 throughout pregnancy, then transfusion can be avoided. Otherwise, if they can't maintain it above 8, then keep pre-transfusion hemoglobin above 8 throughout pregnancy. What it means by pre-transfusion hemoglobin, it means that before you go on to your transfusion, your pre-transfusion Hb should be above 8. So before your next transfusion, when you do your hemoglobin, it should be above 8. So that is what it means by pre-transfusion hemoglobin. So after transfusion, it may go up to maybe 10, but then it will fall before the next transfusion, but never let it go below 8. Or if there is evidence of fetal growth restriction, okay? But sometimes we may not be able to maintain it above 8, especially if there's a large spleen, because they may be pulling into the spleen. So what we do is we just regularly transfuse them, 10 to 15 mils per kilogram blood, about 2 units every month. Okay, next slide. And also for those who are transfusion-dependent thalassemia, that is your thalassemia major, beta thalassemia major, you of course, you just carry on with the regular transfusion, keeping pre-transfusion Hb above 10, because these patients are transfusion-dependent from childhood, so they cannot tolerate lower hemoglobin. So we keep it above 10, pre-transfusion hemoglobin above 10. All this taken from RCOG Green Top Guideline 2014. Okay, so postpartum, very important, is VTE thromboprophylaxis. While in hospital and up to 1 week post SVD, up to 6 weeks post LSCS, contraception is safe. We need to check for iron loading of postpartum, because they may have received blood transfusion during pregnancy. And if you need to give them iron chelation, the only drug that is safe during breastfeeding is desferoxamine. Given subcutaneously. The oral iron chelators is contraindicated during breastfeeding. Next slide. I think in conclusion, in thalassemia in Malaysia, we have a high thalassemia carrier rate, 1 in 10 for HBE, beta, and alpha 0. HBE, beta thal, and Hbh disease are heterogeneous with variable phenotype. And they may present undiagnosed during the pregnancy, as is seen in the first case, right? Next slide. There is a higher risk for alloimmunization. What it means by alloimmunization is the mothers can get red cell antibodies, and then it'll be difficult for them to find a matched blood, or they may hemolyze, if you don't give them proper phenotype matched blood. And also higher risk for getting VTE during pregnancy. And those with iron overload are at higher risk for complications such as heart failure, diabetes, hypothyroidism, infections, and VTE, of course, So iron is not good, Too much iron is not good for the body. Next slide. And thalassemia in pregnancy must be planned, partner must be screened for thalassemia, iron chelation must be optimized before pregnancy. So it's very important to have pre-pregnancy clinics for thalassemia patients. And you need to have a multidisciplinary care for these patients. Obstetrician, hematologist, cardiologist, endocrinologist, all must be involved in their care. Again, I think with that, that's my last slide. Thank you very much for listening. I hope it was clear, and I would be happy to take questions at the end.
Thank you very much, Dr. Jamila, for very, very good presentation, very enlightening a lot of us about the changes of hemoglobin during pregnancy and what is needed to be given. Therefore, after this, I will give to Prof. Rahana to present, and she will talk to us about how to manage thalassemia in pregnancy, as well as I hope she can wrap up. We have already about 3 to 4 questions waiting, so give time for this question and answers, Prof. Rahana. All right, please, Dr. Rahana, present.
Assalamualaikum and good morning. Can you see my slide?
Yes.
Okay. Thank you very much, Prof. Shala. First thing, when we try to choose the topic for our CPC, we decided that we are going to go with a disease with multiple phases or different phases. Because if you can see in the first and second case, the outcome of the pregnancy is totally different. Alpha thalassemia gives a different outcome for that particular patient, as well as the beta thalassemia has a different outcome for that particular patient. So thalassemia in Malaysia, unfortunately, is still underreported. We miss a lot of women with anemia, and we don't actually screen them for thalassemia. So they are left uninvestigated, and some even only diagnosed as thalassemia in the 4th pregnancy, in the 5th pregnancy. Yeah, so it is actually important to screen these women during pregnancy, as this is the best timing that you can catch hold of these women and try to screen them whether they are thalassemic or not. Therefore, I think the primary care is the most important people, because they see these women early in their pregnancies, and they can actually grab the chance to look at the booking hemoglobin and scrutinize all the parameters as explained by Prof. Azma, and how you can actually see whether they are actually thalassemic or they are not. Yeah, in women who has a booking hemoglobin which is less than 11, you should actually look out for the cause. In the history, you can actually ask regarding whether she has heavy menstrual flow that can contribute to the lower booking hemoglobin, or if she doesn't have any of that, then you must suspect thalassemia. We cannot rely on the family history of blood disorder, because in Malaysia we can see a lot of our thalassemic patients, they have been left unscreened. Right, so this is sort of like elaborating more on what Dr. Jamila has explained earlier. So the gist of this diagram is actually trying to explain that in the fetus, early in the life of a fetus, initially they have this embryonic hemoglobin. Yeah, so with time, at around 10 weeks of gestation, this embryonic hemoglobin will start to have a transition to the hemoglobin F, which is the fetal hemoglobin. So at the end, when the baby is born, the baby will have majority of HbF and a minority of HbA. The problem occurs when you have defective in the alpha globin chain, whereby once they have a transition or hemoglobin switch from the embryonic hemoglobin to the fetal hemoglobin, so you have defective alpha globin chain. So, but then you see in the first case, we don't see the earlier appearance of hydrops fetalis, yeah, but we see later at around 26 weeks, and the feature starts to appear around 24 weeks, yeah, because basically in patients who have defective alpha globin chain, sometimes what it does is there is a compensation by the increase in the embryonic hemoglobin, or there is a delay in the hemoglobin switch. Therefore, you see the later presentation of hydrops fetalis. Now we go to alpha thalassemia first. Both alpha and beta thalassemia has different challenges in pregnancy. So in the first patient, we can see that the couple has alpha thalassemia, 2 gene deletion or 3 gene deletion, and therefore they have a 25% risk of having a fetus with Hbh. So let me explain first what are the features of hydrops fetalis. Now, firstly, you may find in majority of hydrops fetalis cases, it will appear between 25 to 34 weeks. Rarely you can see these features before 20 weeks or as late as 42 weeks. So you will define the fetus to be in hydropic, having hydropic features if you have a minimum of 2 features on the right-hand side here. So whether they have pericardial effusion, pleural effusion, ascites, oligohydramnios, or thickened placenta and subcutaneous edema. So actually, to see the fetus, if the fetus has 2 of these features, for example, pericardial effusion and also ascites as demonstrated by the first case, then we will look hard for thickened placenta and also subcutaneous edema. Now, how does it happen? In HB-BUDS, there is a shorter RBC lifespan, therefore the fetus becomes severely anemic. And in the end, it will cause heart failure, and that will lead to the hydropic features that we see. And also the hyperplacentosis as a result of this will cause more problems like mirror syndrome, postpartum hemorrhage in 50% of cases, retained placenta due to the huge and thickened edematous placenta, as well as birth dystocia, because you have a hydropic fetus who is edematous, and therefore delivering the fetus may be difficult. Now, mirror syndrome is actually first described by John Ballantyne, and this mirror syndrome is a maternal presentation that mirrors the fetal condition. So whatever the fetus has, the mother seems to have the same clinical features. The incidence varies a lot between as low as 0.01 to 29% in hydropic fetuses. The onset can be from as early as 16 weeks and can be as late as 34 weeks. The common clinical features in mirror syndrome are weight gain and edema of the mother, which can be demonstrated in 89% of cases, elevated blood pressure in 60%, and also associated with proteinuria in almost 43%. So if you look at this, you can almost think that the mother has preeclampsia. Yeah, but the only difference between the preeclampsia and mirror syndrome, you can see that the fetus is hydropic. So for the first case, what do we do with her for her future pregnancy? As been told by Dr. Jamila, the preconception counseling is the most important part of the management of this patient for her future pregnancy. So during the preconception counseling, we need to discuss with the couple regarding the risk of having fetus with HB-BUDS again, which is about 25%. And we have to inform them that there is availability of prenatal diagnosis. However, there are some patients who are not keen for prenatal diagnosis. They chose to have a screening first for any evidence of fetal anemia and subsequently proceed with definitive prenatal diagnosis. And of course, the last will be when do we terminate the pregnancy if, let's say, the pregnancy is confirmed to have HB-BUDS. So in view of the 25% risk of HB-BUDS, prenatal diagnosis is very important. And we can only go with the invasive prenatal diagnosis, which is amniocentesis. There is another one, which is chorionic villus sampling. However, it is not done in our center. So we will end up with doing amniocentesis. So like I said, there's a screening test for fetal anemia, which is non-invasive by performing a Doppler ultrasound. And once we see there is a feature of fetal anemia, then we can go ahead with the amniocentesis. So amniocentesis can be done as early as 16 weeks, whereby the amniotic fluid is collected and we will send it off to the lab for DNA analysis. Complications associated with amniocentesis can be miscarriage, which is about 0.5%. It can occur within 1 week of the procedure in most patients, or in minority, it can go up to more than a week, whereby the patient will have complication. So once, for example, for that first patient, let's say in the next pregnancy, she decides to get pregnant and we have laid out all the plans and she chose for a prenatal diagnosis by doing amniocentesis at 16 weeks. Therefore, we will perform it at 16 weeks and we will wait for the result. So the result will come back at around, I think, about 3 to 5 days. And then once the diagnosis is confirmed, we will proceed with termination of pregnancy. However, in her case, in the first case, we can see that there is a delay in the termination of her pregnancy, even after we diagnosed that the fetus was having HB-BUDS. So although she did not have a mirror syndrome, but she is absolutely in danger of having developing a mirror syndrome later. But fortunately, she did not have any mirror syndrome, but she did have postpartum hemorrhage. Therefore, if in any patients the diagnosis is made late regarding HB-BUDS, once we diagnose it, what is recommended is we terminate the pregnancy. Now, this is the ultrasound Doppler that we do to screen for fetal anemia. So it's a middle cerebral artery peak systolic velocity, or in short, MCA-PSV. So it can be commenced as early as 16 to 18 weeks gestation, where we perform it and we look at the reading of the MCA-PSV, and subsequently the frequency you can perform it at 1 to 2 weekly and up to 32 to 34 weeks. So the sensitivity of this test to diagnose fetal anemia is about 85%, and the specificity is 100%. So it's quite good. So this is showing on the ultrasound, the fetal head. Yeah, so this is the anterior part of the head. This is the posterior part of the fetal head. And of course, middle cerebral artery is situated anteriorly. So what we do is we put a Doppler and measure the MCA-PSV near to the origin of the blood vessel. And then we use this graph to plot the reading for the MCA-PSV. So what we are aiming is we don't want the reading to be more than 1.5 MOM. There is another test that we can do, which is pre-implantation genetic testing. So it is actually testing on the embryo to determine genetic abnormalities, but the problem is the patient has to go for IVF. So it is very expensive. It is not available in our center, but it is available in private centers, and one of them is Sanford. Okay, so that is for alpha thalassemia, and for the second case in beta thalassemia, it has totally different challenges in the pregnancy. So you are going to deal with a woman who may need multiple blood transfusion, or iron overload if she is a beta thalassemia major, and splenomegaly, as well as the risk of having a fetus with beta thalassemia major. So the pre-pregnancy counseling is very important. So we will explain to the couple. First, we must make sure if the patient's husband is not screened yet, we must determine the status of the partner, whether he is thalassemic or not. And in patients with beta thalassemia major, they can have a problem with fertility. So if they do, then you have to work out on the fertility part in regards to the menstrual history, whether there is a low anti-Mullerian hormone, and also look at the tubal patency of the woman. The semen analysis also should be done. In patients with transfusion-dependent thalassemia, issue of iron overload will be a problem. Therefore, before pregnancy itself, we must look at the serum ferritin. And based on the serum ferritin, then we will work the patient out for any features of iron overload. So for example, you can look at iron deposition in the heart by using the MRI, and iron deposition in the liver also by using MRI. Other investigations in regards to the cardiac function, you can do ECG to make sure that the patient doesn't have any arrhythmias, and as well as the Holter, and also echocardiogram to look at the heart function. And as for the liver, we can send the blood off for liver function test, and also an ultrasound of hepatobiliary system, because they can have, they are prone to get cholelithiasis due to the frequent hemolysis. As for the endocrine part, if you have a lot of iron deposition in the thyroid, then you may have hypothyroidism. So you must send the blood for thyroid function test, as well as in the pancreas, they can have deposition of iron in the pancreas, causing the patient to be diabetic. So if they haven't been screened for diabetes, they should be screened for diabetes. And also for infection due to the frequent blood transfusion in transfusion-dependent thalassemia. So you must look out for HIV, hepatitis B, and C infection. The pre-pregnancy counseling is also a good place to discuss with the patient regarding alteration in the medications. So this has to be worked out with the hematologist. Yeah? For example, if you want to change the chelating agents, if they are on one, so you may want to discuss with the hematologist whether you can change the chelating agents. And others, of course, the screening for red cell antibodies prior to pregnancy to see whether they have any specific antibodies before they get pregnant. Right, so for beta thalassemia, again, it's not so much of trying to tell the patient that you should go for a prenatal diagnosis, but if the patient and husband both are beta thalassemia carriers, so they are at risk of having a fetus with beta thalassemia major. So there is a role to offer prenatal diagnosis in this type of patient, and it has to be only invasive, which is the amniocentesis. And again, because we don't have coronary bleeder sampling, so we can only offer amniocentesis or even chordosynthesis at earliest is 16 weeks. So during pregnancy, it differs whether the patient is non-transfusion dependent or transfusion dependent. So antenatally, for the mother, you have to optimize the hemoglobin. So you might have to have a regular transfusion, and the hemoglobin, as been said, can be aimed for more than 8 grams per deciliter. And the antibody screening should be done at booking and also at 28 weeks if the patient is transfusion dependent. And usually mode of delivery is based on obstetrics indication, and you don't do a cesarean section just because she is beta thalassemia major. Time of delivery is based on case-to-case basis, depending on what obstetric problems she has. And thromboprophylaxis should be considered in the patients, again, based on whether she is transfusion dependent or non-transfusion dependent, or whether she has splenomegaly. And as for the fetus, you must monitor the fetal growth. Let's say if you have the fetal growth which is appropriate around 50th percentile, you may want to monitor the fetal growth monthly. But if you start to see there is the features of slowing of the fetal growth, you may want to monitor every 2 weeks. In the intrapartum period, the most important part will to ensure that the patient has good hemoglobin for delivery. If let's say she has low hemoglobin, which is less than 8, so you may want to transfuse her intrapartumly. Now again, like our second patient, she has a pre-op hemoglobin of 9.7. So if you look at that level, if you look at the patient being asymptomatic, you would say, why should we transfuse her with blood? But because she has a twin pregnancy, right? Therefore, she is at risk of a postpartum hemorrhage due to the over-distended uterus. So in view of that, we should prepare for the possibility of PPH, and that is why we transfuse her with blood, although her HB was 9.7. So again, the postpartum hemorrhage can occur. Therefore, you should look out for this problem and see whether the patient needs for any transfusion. And if she goes for a vaginal delivery, the active third stage management is very important to prevent any postpartum hemorrhage. And in the postpartum period, the VTE prophylaxis should be given 7 days post-SBD. And if she had gone for a cesarean section, it should be given for at least 6 weeks based on RCOG guideline. So breastfeeding is not contraindicated. In fact, it is very much encouraged unless the patient is on chelating agent. So what are the issues in managing thalassemia in pregnancy? So in regards to the topic of termination of pregnancy in patients with alpha thalassemia, whereby husband and wife both either 2 gene deletion or 3 gene deletion, so they are at risk of HB buds. So dealing with the HB buds is quite straightforward. Yeah? So if you have a fetus with HB buds, therefore the termination of pregnancy becomes very clear that you should terminate the pregnancy. However, in the beta thalassemia major fetuses, so let's say you have a couple with both beta thalassemia minor, and they have a 25% risk of beta thalassemia major, and we do a prenatal diagnosis and confirm the fetus to be beta thalassemia major. So what do? Do we offer them termination of pregnancy? So it is still debatable, because the argument is always that in the modern medicine now, we have the availability of chelating agent. So is that a cause for us to actually offer a termination of pregnancy when there is a treatment for it? But again, the quality of life for a patient with beta thalassemia major is very low. And also the mother has a lot of emotional trauma while taking care of their children with beta thalassemia major. So if you look at fatwa, first we look at our legal, our law. So before 120 days, apparently, this is a fatwa from Kuwait, which I came across in one of the papers. And in Kuwait, apparently, they are allowed to terminate a beta thalassemia major fetus, but it has to be done before 120 days. Abortion may not be done except if it is certain that the fetus will be born with severe deformation or physical or mental deficiency, neither of which can be cured. And as well as in Saudi Arabia, they also allow termination of beta thalassemia major fetuses, whereby you can see here, abortion is allowed within the first 120 days of conception if it was proven beyond doubt that the fetus is affected with a severe malformation that is not amenable to therapy, and if his life after being born will be a means of misery to both him and his family, if his parents agree. So the key word here is a misery to the mother and also the child. So what do we have in Malaysia? Based on our law, a medical practitioner registered under Medical Act 1971 who terminates the pregnancy of a woman terminates the pregnancy of a woman if such medical practitioner is of the opinion, formed in good faith, that the continuance of the pregnancy would involve risk to the life of the pregnant woman or injury to the mental or physical health of the pregnant woman greater than if the pregnancy was terminated. So our fatwa says penguguran janin yang berumur sebelum 120 hari adalah harus sekiranya janin itu cacat dan berpenyakit yang boleh membahayakan nyawa ibu. Pengguguran janin yang telah berumur 120 hari atau lebih adalah haram kerana pengguguran itu dianggap satu jenayah ke atas janin yang telah ditiupkan roh kecuali pengguguran itu untuk menyelamatkan nyawa ibu atas sebab kecacatan yang teruk. So basically in Malaysia, the law is if you want to terminate a pregnancy, the main issue is the mother. If it is something, a condition that can jeopardize the life of the mother, therefore you can terminate the pregnancy. But in beta thalassemia major fetuses, if you go by the fatwa from Saudi Arabia and Kuwait, then the keyword of misery will tell you that it is indicated. But so in Malaysia, it is not clear yet, but I think there is some work going on trying to get it to be legalized for beta thalassemia fetuses to be terminated. So in terms of contraception post-delivery, the patients with thalassemia can go on any of these contraceptions. Basically, your aim is try to find a way or a method of contraception that can result in less menstrual flow. So for example, COCP or combined oral contraceptive pills, Implanon, Mirena, and also barrier method. So if you can see here, the multi-load copper IUCD is not recommended because it can be associated with heavy menstrual flow. So you don't want these patients to be more anemic as they already are, because they are already having thalassemia. So what's new in the treatment of thalassemia? I've come across these three mentioned new treatment: stem cell transplantation, gene therapy, and genome editing, all very hi-fi. However, they are all at the level of research and still not there yet for clinical use. So my take-home message will be screening for thalassemia during pregnancy is very important, and you should grab the chance to catch hold of these women and screen them for thalassemia. And in couples with thalassemia, they should be referred for pre-conception counseling to a tertiary center. Prenatal diagnosis is available in our tertiary center for an early diagnosis. Termination of pregnancy is still a debate for fetuses with beta thalassemia major. And please look out for mirror syndrome in cases of hydrops fetalis. If you find one, you should terminate the pregnancy early. With that, I thank you.
Thank you very much, Prof. Rana, for your very, very good presentation. We still have about 8 minutes to kill, so I hope all the panelists can unmute so that we can start with the Q&A. Right. The first question been asked here is that, do we still give hematinics to thalassemic pregnant lady? Can I ask Dr. Jamila to answer this?
We're talking about thalassemia carriers.
Yes.
Not thalassemia, not patients with thalassemia syndrome. So for thalassemia carriers, yes, you can be iron deficient. So we do give these patients hematinics.
Right.
Yeah,
Okay.
yeah, because I think, yeah. And usually, yeah, you know, the iron can have a lot of GIT upset. Yeah, we tend to give it, you know, every other day, 3 times a week, Monday, Wednesday, Friday, to leave a gap, because they do get a lot of, you know, gastrointestinal problems, side effects. And also studies have shown that if you give daily iron tablets, there is actually upregulation of hepcidin, and then you may not absorb, iron. So you need to give a rest day. So that is a new finding. So yes, thalassemia carriers can have iron deficiency, so you can give iron. Sorry, I think my internet is unstable.
It's good, Dr. Jamila. The answer is clearly heard. Prof.
Can I add?
Zahra too.
Prof. Shaila.
Yes.
Can I add to that? You can actually give iron in non-transfusion dependent thalassemia, because during pregnancy, you have to look at the serum ferritin. So there are some thalassemic patients with concurrent iron deficiency anemia. So if you find the serum ferritin to be low in these thalassemic patients, by all means you can give iron supplement. But if the serum ferritin turns out to be normal, therefore you don't have to supplement them with iron, you may want to go with a lower iron supplements such as obimin.
Okay. Right. Thank you very much, Prof. Rana. Prof. Raja Zahra too, do we need to correct this anemic status prior? Does it impair the lab results?
Because for the thalassemia, we just need early sample for the diagnosis of thalassemia. So it should be okay. I mean, we need to correct the patient status. And as we know, if patient with thalassemia major, they also have regular blood transfusions. So we just monitor the hemoglobin, that's all. I mean, what we want to know after the transfusion, all that, we just want to look at the level of hemoglobin. It won't affect the result. But the Hbh analysis and the full blood count early, usually we do it in early stage of, at the early diagnosis as early diagnosis.
Okay, thank you very much. There's a question here, is that the HbE beta thalassemia pregnant woman who is non-transfusion dependent and able to keep hemoglobin more than 8, how far can this patient be managed in primary care? What do you think? Is Dr. Jamila or Prof. Rahana will be better person to answer? I mean, both can answer, please.
Dr. Jamila first.
If the patient, I think for the non-transfusion dependent thalassemias or the hemoglobin E beta thalassemias that are irregularly transfused, I mean, that is a very difficult question. We need to be individualized. That's why actually to manage thalassemia major is actually much easier than the non-transfusion dependent thalassemias actually, because the decision is, when do you transfuse? Will they be okay throughout pregnancy? Will the hemoglobin be above 8 all the time? You need to look at the patient. And I think if the patient has a hemoglobin, baseline hemoglobin of 10, like in the first patient, it will not go down so low. You can actually manage them by the FMS, and then later on they should be referred to the hospital, for delivery. I don't know. How do you answer that, Rahana?
Totally agree, Dr. Jamila. It's a case-to-case basis. For example, if you have come across the second patient just now, again in her third pregnancy, so what do we do with her? So knowing that her history of having to need transfusion during pregnancy, therefore I think she will be, probably if she comes for her first booking visit in KK, subsequently you can refer her as early as in the first trimester to a tertiary center for further management. But if let's say she has no problems during pregnancy, by all means the KK or the primary care can actually look after her together with us.
All right, I think that's a very good answer from both of you. Now, our young doctor here actually asked a question. She says that Dr. Hafizah tanya, she asked about how frequent do we have to monitor the pre-transfusion hemoglobin to make sure it is frequently above 8, or for us to decide whether to transfuse. How is it monthly? How frequent?
Can I answer that?
Yes, please.
A guide will be monthly until about 28 weeks, and then you do it fortnightly. That's what we usually do.
Okay, thank you very much. I think it's inside your presentation as well, right?
Oh, yeah.
Yes. One of our doctors as well has asked here, I think she wants to ask again. I think you have presented this, but let's see, we can just give her a good answer. She says, why a patient who's transfusion dependent hemoglobin has to be kept above 10, whereas the non-transfusion dependent just keep above 8? I think you have mentioned this in the Dr. Jamila. Can you just repeat?
Okay. Because for those who are transfusion dependent, who have been transfused from childhood, they may not tolerate a lower hemoglobin because they used to a higher hemoglobin. But for those who are not transfusion dependent, their baseline hemoglobin will be 7, 6, 7, 7, 8, and they may tolerate a lower hemoglobin. So because their body adapt, all their organs have adapted to a lower hemoglobin, so they can tolerate that, a lower hemoglobin.
Thank you very much, Dr. Jamila. The last one, I think I'll give this to Prof. Rahana. Any updates in utero management of HbBUTs?
Not that I know of. There are some obstetricians who attempted in doing intrauterine therapy, but the outcome is not so good. So even if you manage to maintain the hemoglobin in utero to an optimum level of trying to avoid hydrops fetalis at birth, the fetus still cannot produce normal amount of hemoglobin. So therefore, you can still have outcome of neonatal death.
Okay, thank you very much. I think, there's one more question. Dr. Jamila wanted to add on some more.
Because if you do in utero transfusion, but then when they deliver, you need to have a plan. Are you going to do a bone marrow transplant to save them? Because it's not going to be easy, especially for hydrops fetalis. It's not that they may even require every week blood transfusion. For the rest of their life. So you really need to think properly, if you want to do in utero transfusion. Do you have the facilities to do bone marrow transplant, as soon as they deliver? Can you cope with weekly or 2 weekly blood transfusion? And can the parents cope? Imagine bringing the child to hospital, every week. So all this you need to think very, very carefully.
I think the last question I'm going to give to Dr. Jamila. Somebody write in the last question. I think it's very important. We just spend about 1 minute for that. Looking for at prevention of major thalassemia. What else can be done apart from just early screening? Don't get married.
I would say, of course, a lot of education. And I think just screening on its own is not enough. We need to have a good prenatal diagnosis service in place, and also a good, even PGD, prenatal, and CVS, a good molecular lab, and a termination of pregnancy if the parents are agreeable, if they have a severe a fetus with severe disease. So everything has to be in place. Screening alone, I don't think it will be successful. Just screening, pregnancy screening or Form 4 student screening, but I think everything has to be in place. Prenatal diagnosis is very important.
Okay. Thank you very much to all the speakers, Dr. Nur Hafiza, Prof. Raja, Dr. Jamila, Prof. Rahana, and all the audiences who listens and as well as giving us the questions. There's a link where Encik Bohari here for attendance. And after this, we'll pass back to Encik Bohari for Kahoot. Thank you very much for everybody. Thank you very much for today's session.
Thank you very much.
Thank you, everyone. Thank you, Prof. Shaila. Thank you, Rahana, Azma,
Thank you, Dr. Jamila.
Hi, are we still here? Are we okay? I sakit perut tadi tau. Sorry. Are we offline? Are we offline?
Not yet.
We're still online.
No, we
better mute first. Takut dengar.
We are, they're all leaving.
you.